Good morning, everyone. My name is Dr. Nikolay Neofidov. I'm from Russia. I'm a neurologist from Russia. Today, I'd like to present some short but essential information for MOG-associated disease and discuss differential diagnosis for some demyelinating diseases. But firstly, I would like to say thank you for Dr. Bernard, Dr. Stein, and Dr. Naka for this great opportunity. Okay, this is content of my presentation. As you can see, we'll speak about clinical case, terms and definitions, pathophysiology, then about prevalence and clinical feature of the MOG-associated disease. And from my point of view, the diagnostic criteria and differential diagnosis are the most important part of my presentation. I will try to show similarities and differences between different demyelinating diseases. And of course, we will speak about treatment in the end of my presentation. Firstly, we will speak about clinical case. This clinical case is from my real practice in Russia because I worked in multiple sclerosis center and other autoimmune diseases of central nervous system for 3 years. Let's call her Alexandra. This is of course fake name. She's 26-year-old female. She had 3 episodes of neurological symptoms. First one was in 2015. She had optic neuritis on the right side. It had very good response to intravenous steroids. She had full recovery after that. And the second episode was in 2016. It was optic neuritis of the left side. And after that, she has decreased visual acuity and scotoma on the left side, despite she was treated with intravenous steroids. And the last episode was in the 2017. She had urine urgency and weakness in the lower limbs. And now we can find in her neurological status signs of pyramidal dysfunction. As you can see, she doesn't have any remarkable information in the medical history or physical examination. Your family history also is unremarkable. Workup. There is no any abnormalities in her workup in 2017, apart from high protein in cerebrospinal fluid. She had negative OCB, oligoclonal bands test, serum aquaporin 4 IgG. This is a very specific test for neuromyelitis optica spectrum disorder. And angiotensin converting enzyme. This is very specific test for sarcoidosis. Her brain MRI was unremarkable, but we find a very typical lesion on her spinal cord MRI. As you can see, this is a very long and widespread lesion, which more than half of the diameter of the spinal cord. It's not so specific picture. We will speak about that later in differential diagnosis. But we didn't find any lesions in her brain, and we will continue speak about Alexandra after the discussion about MOG-associated disease and about differential diagnosis. MOG-associated disease is not so common disease. It's a very rare disease, but we should know diagnostic criteria for that because it's very important to divide different demyelinating disease because it's very important for treatment. We will speak about this later too. Terms and definitions. Firstly, what is MOG? MOG is myelin oligodendrocyte glycoprotein. This is very important component of the myelin and central nervous system. There are a lot of terms which can describe this disease. You can see them on the screen, but there is only one definition for this group of diseases. This is a group of rare inflammatory demyelinating diseases of the central nervous system characterized by acute or subacute development, which means less than 1 week, monophasic or recurrent course, and of course, presence of anti-MOG IgG. It's very important for diagnosis. MOG is very important for central nervous system because, as you can see, this is a more superficial layer of the myelin, and it plays an essential role in maturation of central nervous system and can mediate interactions between myelin and the immune system. But on the other hand, this position, superficial position, lead to a lot of contacts with the immune system, and MOG is highly specific autoantigen. It can activate the classic pathway of the complement cascade and lead to inflammation in the central nervous system. What about prevalence and demographics of the MOG-associated disease? Firstly, I would like to say about two phenotypes. There are only two phenotypes of this disease. ODEM-like phenotype. What is ODEM? ODEM is acute demyelinating encephalomyelitis. This phenotype is more typical for children, and opticospinal phenotype is more typical for adults. This is not so common disease, but you can find this disease among patients from 1 year old to 80 years old. Recurrent course occurs from 44 to 83% of patients. And the most common manifestation of the disease is optic neuritis. It can be unilateral, it can be bilateral. The second place is transversus myelitis. Transversus myelitis can be longitudinal widespread or longitudinal limited. What does it mean? It means that longitudinal widespread transversus myelitis, this is transversus myelitis which more than 3 segments of the spine and more than half of the diameter of the spinal cord. On the other hand, longitudinal limited transversus myelitis means that it is less than 3 segments of the spine. And diagnosis criteria. It's very important in 2021 to use diagnosis criteria because we can't make the right diagnosis from our thoughts or our point of view. We need to use diagnosis criteria to be exact and precise. There are 2 groups which develop diagnosis criteria for MOG-associated disease. I would like to draw your attention to the fact that the most important criterion is seropositivity for anti-MOG IgG. It's very important to receive positive result of this test from serum because without that, you can't make this diagnosis. The most important part of my presentation is differential diagnosis. Why it's so important? The purpose of my presentation is to show that you can't rely on one source of information in your clinical practice because sometimes different diseases have a lot of similarities in their clinical course. MRI picture, and laboratory results. And you need to combine all of these sources of information to fit criteria and to make right diagnosis. Firstly, in the previous presentation, we speak a lot about multiple sclerosis. Now I want to speak about neuromyelitis optica spectrum disorder and MOG-associated disease. The red color means that this is typical symptom or syndrome for this group of disorders, but you also can find areopostrema syndrome, which means nausea, dizziness, vomiting, in multiple sclerosis, for example, or in MOG-associated disease. You don't have 100% guarantee that this is specific for neuromyelitis optica spectrum disorder. This is more typical, but not specific. I can also say the same thing about the encephalic syndrome and about ADEM, because there are a lot of atypical types of multiple sclerosis with encephalopathy and with symptoms of acute demyelinating encephalomyelitis. You can guess, but you can't rely on clinical course alone. As you can see, the age of onset is very similar between MS and neuromyelitis optica spectrum disorder. MOG-associated disease is more typical for children, but as our patient, you can find a lot of adults with the onset of the MOG-associated disease. Progressive course is very typical for multiple sclerosis. You will never see patients with neuromyelitis optica spectrum disorder or MOG-associated disease, which have deterioration of his condition between relapses. This is very important to understand that progressive course is the most typical feature on this page. Okay, what about MRI? We said about typical picture of lesions in multiple sclerosis. I can add only that usually they are perpendicular oriented to the ventricles, as you can see here, so-called Dawson's fingers. You can find different lesions infratentorial with different distribution in stem or in cerebellum. This is very typical picture of multiple sclerosis. Great lesions in the hemispheres is very typical picture of aquaporin 4 associated disorders, or I called them neuromyelitis optica spectrum disorder. But you also can find infratentorial lesions, which is more typical for aquaporin 4 spectrum disorder. It is areopostrema involvement. This is the lesion which is tied to the bottom of the fourth ventricle. And it's very important to lesions in the diencephalic region are very typical for aquaporin 4 associated disorder. These two type of lesions, we can of course see they in the multiple sclerosis, but very rare, really very rare. It's very typical for aquaporin 4 associated disorder. On the other hand, in MOG-associated disorder, you can find cloudy lesions, infratentorial lesions, as on this picture, and you can find the same great lesions in the hemispheres. Some children with MOG-associated disease have lesions in the deep gray matter. But we have a lot of similarities between all of these pictures. Look at this lesion, and this lesion. They look like very similar. This lesion, this lesion and this lesion are very similar too. You can find involvement of deep gray matter in aquaporin 4 associated disorder and in MOG associated disease. This is my point. I would like to say that you should use all sources of information and combine them to make right diagnosis. And to prove my point of view, I would like to ask one question. I don't have answer for this question, of course, but can you divide these pictures to different entities? I mean, aquaporin 4 associated disorder and MOG associated disorder. I don't think so, and I think that nobody can, but this is different diseases. What about typical lesions in spinal cord? It's a very interesting question too. Firstly, I would like to describe typical picture of multiple sclerosis. As you can see on this picture, usually lesions in multiple sclerosis are small and less than 2 segments of the spine, and they usually have peripheral distribution, and usually they are less than half of the diameter of the spinal cord. Typical lesion for I can describe typical lesion for aquaporin 4 associated disorder, like a very long lesion, more than 3 segments of the spine, and more than half of the diameter of the spinal cord. You can call it butterfly pattern if you see. On the end, for MOG-associated disease, lesion in distal portion of the spinal cord is more typical. I mean, in lesion in spinal cone will be more typical for MOG-associated disorder. But again, sometimes we have patients with multiple sclerosis who have a very long lesion and pronounced atrophy of the spinal cord, like aquaporin 4 associated disorder. Or we can find people with patients with very small lesion in aquaporin 4 associated disorder and with aquaporin 4 associated disorder. What does it mean? It means that if you have typical picture, you can make conclusion, but sometimes MRI picture is not so typical and you need to have information from other sources to make right diagnosis. Again, the question, can you divide all of this picture in the 2 entities? Again, this looks like very similar. Cloudy lesions, more than 3 segments of the spine. Nobody can, but this is different diseases. What about laboratory results? In 2021, a lot of doctors like to rely on laboratory results, but if you can see, there is no specific test to understand what is that. I mean, of course, oligoclonal bells you will see very often in among patients with multiple sclerosis, but you can find them in among patients with neuromyelitis optica spectrum disorder 2 and MOG associated disorder 2. You can find MOG IgG among patients with multiple sclerosis and and among patients with MOG IgG. It's not so reliable. Unfortunately, we can't use only one source of information. What should we do? We should use criteria, because criteria is a very good option to make right diagnosis and prove your point of view for other doctors or for your patient. Again, I want to demonstrate these two very important criteria for MOG-associated disease. Of course, there are some red flags which you can use to divide different diseases. Progressive course, as I said, is more typical for multiple sclerosis. If you have a patient with very rapidly developed symptoms, you should think about ischemia. If you have patient with worsening symptoms for weeks, it can be sarcoidosis or neoplasia. If you see on MRI typical MS picture, I mean dorsal fingers, more likely it is multiple sclerosis. Oligoclonal bands is very typical for multiple sclerosis, but not very specific. But sometimes you can receive false positive results, or you can, you can try to make insignificant test. I mean, we don't know now significance of MOG IgM and IgA. Why? Because as you remember, the MOG is the most superficial layer of the myelin, and when other different agents will destroy myelin, they will destroy MOG too, and it will lead to interactions between immune system and MOG and creation of MOG IgM and IgA. But this is not cause of the pathological process. This is just a consequence. Of course, sometimes you will have double positive tests for IgG to aquaporin 4 and MOG. In this case, I can recommend you to try again. What about, and of course, you need to think about alternative diagnoses, because the myelin disease can be imitated from neurotuberculosis, neuroborreliosis, neurosarcoidosis, Behçet's and Leber disease, vasculitis, lymphoma, neoplasia, histiocytosis, gliomatous, Press syndrome, PML, infectious and autoimmune encephalitis, and others. This is very important to remember about that, and check your minds maybe to prevent any mistake in your diagnosis. And this is the most important question of my presentation: who should be tested for MOG IgG? The answer is every patient with optic neuritis should be tested for that. Every patient with, all patients with atypical multiple sclerosis, with stem symptoms, with encephalopathy and lesions in the brain, and of course, patients with transversus myelitis. This is an algorithm from our colleagues from Oxford. They created that in 2017. It's very good algorithm, I think. What about our patient? Unfortunately, we don't have validated MOG IgG test in Russia. And in 2017, we decided to start treatment with anti-CD20 therapy. Why? Because diagnosis was seronegative neuromyelitis optica spectrum disorder or MOG associated spectrum disease. And rituximab, it's a good news, is effective in both cases. Because rituximab is the anti-CD20 therapy, it means that, this drug will decrease the amount of B cells in the blood and prevent aggression by immune system. There are no lot of other side effects with rituximab, and usually rituximab is very well tolerated from patients. Okay, what about treatment now? There are no clear recommendations for the treatment of MOG-associated disease. We have only weak evidence for treatment with low-dose oral steroids, IVG, rituximab, anti-CD20 therapy, and other oral immunosuppressants. But why is so important to divide multiple sclerosis, to separate multiple sclerosis and MOG-associated disease? Because some treatment for multiple sclerosis will harm your patient with MOG-associated disease. I'm speaking about interferon beta, of course. This is a very convenient algorithm for treatment of MOG-associated disease. It's a little controversial. Of course, I'm sure that in case of relapse, you will use intravenous steroids or plasma exchange to decrease the inflammation in central nervous system. But when we speak about preventive treatment, we don't have strong recommendations for that. I prefer start preventive treatment from monoclonal antibodies because it's very safe and effective. But some other doctors can start preventive treatment from oral prednisolone. I don't like this because there are a lot of side effects from this treatment. On the other hand, some doctors can prefer oral immunosuppressants. I don't like them too. In Russia, we had some problems with immunoglobulins because they're so expensive, and I really prefer to start my treatment from monoclonal antibodies. I think this is the end of my presentation. Thank you very much for your attention. And do you have any questions?